Alterations in oxygenation, upper respiratory disorders. The average person will develop 3 to 5 upper respiratory infections on an annual basis that have the potential to develop into more serious infections. Rhinitis is also known as the common cold. It's actually inflammation of the nasal mucous membranes that can be acute, chronic, or allergic. And it's most commonly caused by the rhinovirus through inhalation or contact with contaminated items. Allergic rhinitis will be caused by hypersensitivity reactions to specific allergens. We're going to see sneezing, nasal congestion, rhinorrhea, which is a clear nasal drainage, a sore throat, watery eyes, cough, low-grade fever, headache, aching muscles, and malaise. We treat it with antipyretics, decongestants, antitussives, saline gargles, saline spray, and antihistamines for the allergic rhinitis. We need to be sure we provide client education on prevention and minimizing potential complications, along with hand washing. These clients are going to be most contagious in the first 3 days. Gerontological considerations. We know that rhinitis can be potentially serious in the older adult, and they should seek medical care if their symptoms do not resolve in 7 to 10 days, or if their breathing is compromised. In addition to providing client teaching on over-the-counter or steroid medications, because they may have an undesired effect, especially in the older adult. Sinusitis is also known as rhinosinusitis. It's inflammation of the sinuses, and it's classified according to its duration. It occurs most often in the maxillary sinus. These clients will have a headache, fever, pain over the affected sinus, nasal congestion with postnasal drip, which will eventually lead to a cough, and pressure around the eyes. We treat it with saline irrigations, sometimes antibiotic therapy, vasoconstrictors, and nasal corticosteroids. However, surgical management might be done for chronic sinusitis. There's a procedure called the Caldwell-Luke procedure, or an external sphenoethmoidectomy, which are more radical treatments to remove the diseased tissue or alternate drainage openings. Postoperative, we would observe for repeated swallowing, because this can indicate hemorrhage or bleeding down the back of the throat. We check their optic nerve function to make sure there was no damage to that nerve. Take the temperature every 4 hours and check for pain relief. Administer analgesics as indicated. Ice compresses might be very beneficial. Nasal packing and dressing under the nares. This is called a mustache dressing. Avoid straining or blowing the nose for at least 10 to 14 days. We can encourage mouthwashes, humidify the air, encourage an increased fluid intake, nasal decongestants, and antihistamines per orders. Nutritional recommendations would include increasing vitamin C and zinc when the client begins to experience these symptoms. They may help shorten the duration of the episode. So which of the following statements made by a client with sinusitis would indicate to the nurse that further teaching is required? I will put ice packs on my nose 3 times each day. Application of ice packs is not a standard treatment for sinusitis. And this statement will need clarification for the client. Pharyngitis is frequently associated with rhinitis from the postnasal drip or other respiratory infections. We see inflammation of the throat that's caused by viruses or sometimes bacteria. A group A streptococci or strep throat would be the most serious, and this can lead to cardiac or renal complications such as endocarditis, rheumatic fever, or glomerular nephritis. It's highly contagious from inhalation or direct contamination with droplets. These clients experience a sore throat, dysphagia, fever, headache, white or an exudative patch over the tonsillar area, and swollen glands. We're going to manage it with a throat culture and antibiotic treatment if it is a bacteria, and encourage these clients to make sure they're taking in adequate fluids. If they keep their throat moist, it doesn't hurt to swallow as much. Tonsillitis and adenoiditis is most common in children. We see it as being a primary infection in the tonsils or the adenoids, or it could be a secondary infection from upper respiratory infections. A chronic tonsillar infection would include partial upper airway obstruction, while a chronic adenoidal infection may also lead to otitis media. The client may have a sore throat, difficulty or pain with swallowing, fever, malaise, enlarged adenoids, nasal obstruction, or snoring. We treat it with antibiotic therapy, analgesics, or saline gargles. Surgical management would include tonsillectomy and adenoidectomy for those clients that have repeated infections, sleep disorders, chronic tonsil enlargement, and repeated otitis media or hearing loss. Nursing management postoperatively would include an ice collar, monitoring the vital signs, warm saline gargles, ice chips and cold fluids, and monitoring for bleeding. So after a client undergoes surgery to the upper respiratory tract, the nurse is going to monitor the client for a patent airway. First and foremost, we have to do our ABCs. It's always the primary assessment to be made after surgeries. A peritonsillar abscess develops in the connective tissue between the tonsil and the pharynx, possibly following a streptococcal or staphylococcal tonsillar infection. These clients have difficulty and pain with swallowing, fever, malaise, ear pain, and difficulty talking. We can do sensitivity studies and culture of those drainages to potentially find the right treatment. Medical management would include immediate treatment to prevent sepsis, and this is going to include that antibiotic therapy. Surgically, we can aspirate that abscess or do a surgical incision and drainage. As nurses, put them in a semi-Fowler's position to help prevent aspiration. Apply that ice collar, topical anesthetics, throat irrigations, and drinking fluids that are cool or room temperature. And observe for respiratory obstruction such as dyspnea, restlessness, or cyanosis, or excessive bleeding. Laryngitis is an inflammation and swelling of the mucous membrane. It's frequently caused by upper respiratory infections or an excessive use of the voice, allergies, or smoking. These clients cannot speak above a whisper, or they may have complete aphonia, which is the total loss of the voice, throat irritation, a dry, non-productive cough, And if hoarseness lasts for longer than a couple of weeks, a laryngoscopy may be indicated. A persistent hoarseness can be a sign of laryngeal cancer. So to manage this, we encourage complete voice rest, treatment or removal of the cause, and antibiotic therapy if it is a bacterial cause. Nursing management, we always encourage smoking cessation. Epistaxis is also known as a nosebleed. It's a rupture of tiny capillaries in the nasal mucosal membrane. Risk factors include trauma, systemic infections such as rheumatic fever, local infections, a dry nasal mucosa, hypertension, aspirin, nasal tumors and blood dyscrasias, or cocaine abuse or other inhaled drugs. These clients, we assess them using a nasal speculum and a tongue blade to help reveal the bleeding site. We can stop epistaxis with direct continuous pressure, ice packs, a topical vasoconstrictor, and sometimes nasal packing. Surgically, however, it may require some cauterization or electrocautery or a balloon-inflated catheter. Nursing-wise, we're going to make sure we get vital signs and look for evidence of continued bleeding, which would also include frequent swallowing, humidification, nasal lubricant, and can encourage avoiding vigorous nose blowing or nose picking. So the nurse is teaching first aid class for clients. The topic is treatment for a nosebleed. One of the parents indicates the need for further treatment with which of the following statements? Flushing the nose with warm water. A nasal obstruction will interfere with air passage. It's caused by a deviated septum, nasal polyps or grape-like swellings, and hypertrophied turbinates. These clients may have a history of sinusitis. They may have difficulty breathing out of one nostril or both, and they may have frequent nosebleeds. We can manage it with steroidal nasal spray or surgically with a submucosal surgical resection, a septoplasty, polypectomy, rhinoplasty, or nose construction. Nursing management includes nasal packing postoperatively, which requires mouth breathing, so these clients are going to require frequent oral care. Ice packs, a semi-Fowler's position, obtaining vital signs, and again, that oral hygiene. Fractures of the nose are usually caused by some sort of trauma. We'll see swelling or edema of the soft tissue. There may be external and internal bleeding, nasal deformity, nasal obstruction, or cerebrospinal fluid, which we can test with a dextro stick, or we look at drainage on a white gauze. If there is a halo around the drainage, that may indicate CSF. Medically, we apply pressure to reduce some fractures. These clients may require cold compresses. And surgically, complex fractures may be treated with a splint. Nursing management includes elevating the head of the bed, applying ice, analgesics, assessing the airway for any obstruction, pupillary responses, level of consciousness, periorbital edema, and the level of anxiety. Laryngeal trauma and obstruction is a really serious and potentially life-threatening complication or condition. We often see these as a result of motor vehicle accidents or just blunt trauma in the neck region, or maybe even intubation. These clients may have some neck swelling, bruising, and tenderness. They may be experiencing stridor, dysphagia, hoarseness, cyanosis, and hemoptysis. We may do a laryngoscopy with these clients or an X-ray. Medically and surgically, we need to make sure they have that patent airway. It may be necessary to do a Heimlich maneuver, and severe obstruction would require a tracheostomy. As nurses, we obtain vital signs, monitor the respiratory pattern and breath sounds, nasal swelling, bleeding, and assess for laryngeal edema. Obstructive sleep apnea is a recurrent and frequent episode of upper airway obstruction and reduced ventilation. There's different classifications, and this includes central, which is the failure of the brain to signal the body to breathe, obstructive, and complex, which is a combination of central and obstructive. These clients frequently snore loudly. They have a cessation of breathing for at least 10 seconds, and they will awaken suddenly with a loud snort. They frequently have daytime fatigue because they're being awakened so many times in the middle of the night. Morning headache, inability to concentrate and forgetfulness, sore throat, enuresis, which is the need to urinate during the night, and erectile dysfunction. We diagnose sleep apnea with polysomnography. Risk factors for obstructive sleep apnea syndrome include obesity, cigarette smoking, and older age. Might also include hypertension and an increased risk of stroke. So medically, we encourage weight loss, smoking cessation, eliminating alcohol use, using special pillows, the use of a continuous positive airway pressure, or a CPAP, or a bilevel positive airway pressure, which is a BiPAP. Surgically, we can do a uvulopaleatopharyngeoplasty and a tracheostomy. Nursing management includes reassurance, appropriate education and explanations, maybe referring them to self-help groups and counseling. Laryngeal cancer causes may include different carcinogens, such as tobacco, alcohol, pollutants, chronic laryngitis, and acid refluxes. These clients may have a persistent, progressive hoarseness, swelling, or lump in their throat or neck, dysphagia, and weight loss. Diagnostically, we may do a laryngoscopy, biopsy, CT scan, MRI, or PET scan. Surgical management includes chemotherapy, radiation therapy, laryngectomy, and as nurses, we would assess for hoarseness, dysphagia, dyspnea, burning in the throat, anxiety levels, coping strategies, check their ability to communicate, and aspiration prevention. So alternative means of communication is frequently done after a laryngectomy, or we have a tracheostomy for some reason. So laryngeal speech will be used after a laryngectomy. Esophageal speech would be the regurgitation of swallowed air and the formation of words with lips. An artificial or electric larynx is a throat vibrator that's held against the neck, and it projects sound into the mouth. A tracheoesophageal puncture is a surgical insertion of a prosthesis. Psychosocial issues, we need to assess for social isolation, help promote positive self-esteem, encourage social relationships, and support services. A tracheotomy is a surgical procedure that makes an opening into the trachea. And that tracheostomy is a surgical opening into the trachea in which a tracheostomy or laryngectomy tube would be inserted. So it's more than just the hole, it's an actual tube that's placed into the trachea. These can be temporary or permanent. As nurses, we need to monitor the vital signs, breath sounds, their skin color, level of consciousness, their mental status, airway patency, and monitor the stoma and secretions. These clients frequently will have significant secretions. Provide routine tracheostomy care, suctioning, and elevate the head of the bed. So with endotracheal intubation and mechanical ventilation, we use this with clients that are having respiratory difficulties or the inability of the client to maintain an open airway on their own. Mechanical ventilation can provide negative pressure or positive pressure. With these clients, we monitor vital signs, ABGs, the oxygen saturation, mental status, confusion, agitation. Make sure you auscultate the lungs. Suction is necessary. Provide humidification. Provide alternative methods of communication. But realize that many of these clients may require sedation in order to maintain their airway.